Dear audience, ladies and gentlemen, in the next few minutes I would like to show you my 12-month progression. My name is Endre-Botond Gagyi. I am a first-year Ph.D. student at the Center for Translational Medicine. My vision regarding to this topic is that we can reach a state where we can prevent most of the patients from the recurrence and the progression of acute pancreatitis, and my mission is to reduce this recurrence and progression rates. A brief overview of my research projects. The first one is the risk factors of acute pancreatitis progression into recurrent acute pancreatitis and chronic pancreatitis, which will be a systematic review and meta-analysis. Let me briefly introduce its background. The incidence of acute pancreatitis varies globally, affecting from 5 to 80 people per 100,000 and appears to be increasing around the world. Most acute pancreatitis can be completely recovered after standard treatment, but a proportion of patients eventually develop recurrent acute pancreatitis up to 35%, or chronic pancreatitis up to 24%. On the right figure, you can see the central acute pancreatitis event model by VIII et al., which states that acute pancreatitis, recurrent acute pancreatitis, and chronic pancreatitis represents a disease continuum. Data on the risk of developing REP and CP and factors affecting disease progression have been heterogeneous, and there is no comprehensive work in the topic. However, in order to reduce this recurrence and progression rates, it is essential to know all the contributing factors of progression. Therefore, our aim is to comprehensively assess and objectify all the risk factors that can contribute in the progression of acute pancreatitis. We would like to identify risk factors at this stage, specifically focusing on factors that contribute to acute pancreatitis progression rather than the risk factors for AB itself. As this study examines the risk factors of acute pancreatitis progression, we use the PRIO framework for posing the question. The population includes patients with the first episode of acute pancreatitis or patients with recurrent acute pancreatitis. The exposure involves the presence of a risk factor. The comparison is the absence of a risk factor, and the outcomes are either recurrent acute pancreatitis or chronic pancreatitis. We hypothesize that the presence of a risk factor increases the risk or odds of developing recurrent acute pancreatitis or chronic pancreatitis in these patients. To achieve our goal, we have done a systematic search in 3 major databases in PubMed and Cochrane Library on the 25th of October 2022 using this search key. Here you can see the flowchart of our selection. Out of 23,000 articles, we included 71 in the quantitative synthesis after title, abstract, and full text selection. I'm going to show you some results. On this forest plot, we investigated the association of male sex and the risk of recurrent acute pancreatitis. 28 retrospective and prospective core studies were included in the analysis. The exposure group includes male patients, the comparison includes female patients. The event of interest was the development of recurrent acute pancreatitis. As we anticipated considerable between study heterogeneity, a random effect model was used to pool effect sizes, and for the effect size measure, we used odds ratios with 95% confidence interval. Here we found that male patients have a 46% higher risk of developing recurrent acute pancreatitis compared to females. And since the confidence interval does not include one, this result is statistically significant. Here we investigated the association of alcoholic etiology and the risk of recurrent acute pancreatitis. And we found that patients with alcoholic etiology have a 76% higher risk of developing recurrent acute pancreatitis compared to patients with other etiologies. This result is also statistically significant. The heterogeneity is 81%, which is a considerable heterogeneity. This high level of heterogeneity can be explained by a lot of things. Even though all articles contains all sorts of etiology, but the proportion of etiological composition of the patients is different in each study. There are differences also in severity, in age, in sex ratio, etc. We also found that patients with smoking, hypertriglyceridemia, diabetes mellitus, pseudocysts, and good peripancreatic fluid collections were associated in an increased risk of recurrent acute pancreatitis. These results are all statistically significant. Here you can see a summary table where we illustrated the association of various parameters and the risk of recurrent acute pancreatitis. Here each row represents a separate meta-analysis calculations. The first column includes the exposure group, the the control group, the outcomes were the development of recurrent acute pancreatitis. In the fourth column includes the population. We analyzed the pediatric and adult population separately where it was possible. The fifth column includes the number of included studies in the respective analysis. The sixth column includes the total number of patients. The 7, 8, 9 column includes the effect size measure with the 95% confidence intervals. We use this ratio for every dichotomous outcomes. The 10th column includes the I-square heterogeneity statistics, and in the last column we highlighted the significant results with stars. And the previously presented results are highlighted with the red boxes. This second summary plot is similar to the previous one, but here we illustrated the association of various parameters and the risk of chronic pancreatitis. On this third summary plot, we illustrated every continuous outcomes. The effect size measure here was a mean difference with 95% confidence intervals. On this three summary plot, there are over 100 separate meta-analysis calculations with 26 significant results. The strength of our meta-analysis is the first in the topic. Its comprehensiveness, investigating over 62 different parameters effect on the progression of acute pancreatitis. Our study also identified male sex, alcohol consumption, and smoking as a risk factor on the whole acute pancreatitis, recurrent acute pancreatitis, and chronic pancreatitis axis. The limitations is the majority of the included studies were retrospective and the presence of the confounding factors. We have so far identified several modifiable risk factors, which is clinically important because by eliminating these risk factors, we may be able to reduce the recurrence and progression rates in these patients. This is the current status of our manuscript. We would like to submit to the American Journal of Gastroenterology. Our second project will be also a systematic review and meta-analysis, and it also focuses in the progression of pancreatitis. A few words about the background. The annual incidence rate of chronic pancreatitis varies between 5 and 12 cases per 100,000 person years. Chronic pancreatitis is a severe condition that greatly deteriorates quality of life and reduces life expectancy, and currently there is no specific curative treatment available. A common belief is that acute pancreatitis and chronic pancreatitis represents a disease continuum, as illustrated by the sentinel acute pancreatitis event model. This model posits that initial sentinel acute pancreatitis event sensitizes the pancreas to recurrent acute pancreatitis, which subsequently leads to chronic pancreatitis as a result of ongoing stressors and inflammatory responses. While the sentinel acute pancreatitis event model is an interesting hypothesis, it implies that all chronic pancreatitis cases originate from acute pancreatitis. However, there is a significant part of chronic pancreatitis patients with no history of prior acute pancreatitis episodes. In light of this discrepancy, our aim is to comprehensively assess all the acute pancreatitis episodes that occur before the development of chronic pancreatitis. This will provide a more comprehensive understanding of the relationship between acute pancreatitis and chronic pancreatitis and help refine the existing models of disease progression. In the study, we would like to assess the proportion of chronic pancreatitis patients with no history of prior acute pancreatitis episodes, and at the same time, we would like to know the specific characteristics of these patients' populations. How do they differ from other chronic pancreatitis patients? We have done preliminary research already. There are 6 key articles. The topic is feasible. A brief summary of my research projects. I would like to finish the first one by the end of September and the second one by the end of this year. And, thank you for your attention.
Have you found any protective factors?
Yes, we found two parameters which were associated with a lower recurrence rate. namely severe pancreatitis and biliary pancreatitis.
Kind of things which are difficult to explain. What is your explanation to both?
Possible.
Like, why is it more likely to not get recurrent pancreatitis if I've got a severe one? And why do I have a lower chance of not having recurrent disease if I've got hypertension? We know that hypertension versus the disease course from other studies.
Yes, possible explanations can be the possible speculative, or how would I say, the high mortality rate, the high degree of tissue loss due to the tissue necrosis, and there is a called burnout hypothesis, which also speculative, but states that the pancreas, after a severe inflammation, it desensitizes somehow and will be less likely get another one. So these things are
Hypertension.
Hypertension. It is associated. It is not significant.
I'm just curious, like, how would you explain this male sex? Is it due to more risk factors that this is considered to be one risk factor, or was your explanation behind? Thank you.
Behind the male sex?
Being a risk factor for recurrent.
So what we see is an association, but of course behind it there is a lot of confoundings. So males usually among the males usually are more heavy drinkers, are more heavy smokers. So,
Male sex belongs to preventable lifestyle choices these days. So, you know, I mean, I'm just joking, but lots of diseases. But it will be interesting to see what happens on patients who are on complete androgen blockade for their urological prostate cancer. Do they get a lower chance of recurrence? Is just the hormonal stuff, or what is the reason for that? A little interesting to see. Transgender females or ex-males, do they have a lower risk? That would be interesting. Maybe we'll have enough data in a couple of decades.